In children and adolescents, although we think they tend to have less chance of getting back pain, but the research has shown almost 10 to 30% of normal pediatric population will experience back pain at some point by the time they reach adolescent. So a detailed history along with red flags and physical examination along with some special examinations like we discussed the Adams forward bending test for the deformity, the scoliosis, along with examination of the deformity of the back is very important in children. So this is the Adams forward bending test in the normal spine. While standing it is straight and while bending it is again straight. Whereas in the case of scoliosis, it is curved like this, and when the patient bends down, the rib hump becomes prominent on this side, and the curvature is more pronounced. So we have to again examine the foot, hip, pelvic obliquity, and limb length discrepancies in these cases, especially more important in children. So the differential diagnosis of back pain in children are non-specific or mechanical low back pain, or could be associated with pars lysis, that is spondylolysis and spondylolisthesis. There could be cases with Scheuermann's kyphosis, that means there is a problem with the ring epiphysis of the vertebral bodies. Likewise, deformities like scoliosis could be there. There could be disc herniations, which are not that common in children, but still we have to consider disc herniation in children. And trauma is the other cause of back pain in children. Likewise, infections and neoplasms, which could be again benign or malignant, are other possibilities that we have to rule out while approaching children with low back pain. So in adults, there are unique problems associated with aging spine because of the osteoporotic compression fractures and degeneration of the spinal structures. So the disorders associated with aging that produce back pain could be disc degeneration alone, osteochondrosis, or prolapsed intervertebral disc. There could be degeneration of the facet joint, producing back pain, especially with extension of the back. Degenerative spondylolisthesis could be there. There could be spinal stenosis, which present with back pain and the pain radiating to the lower limbs, mostly presenting with history of claudication. And there could be spine deformities even in adults. There could be osteoporotic vertebral compression fractures, pathological fractures, most commonly because of metastasis, and there could be cases presenting with infections. So while approaching a case with low back pain in adults, you have to consider all the structures around in the vertebral column to see for the potential cause of low back pain. So these are the osteoporotic compression fractures, could be anterior compression, anterior-wise compression, or codfish vertebra, or in the form of vertebra plana, or linear symmetrical compression both anteriorly and posteriorly. So again, this same thing pictorially, and the alerts for juvenile and adolescents should be infection, tumor, Scheuermann's disease, and spondylolysis up to the age of 20 years. Whereas in young adults, it could be because of the back pain, could be because of spondyloarthropathy or traumatic fractures. In middle age, it is the disc degeneration that is very common between 35 to 40 years of age to up to 70 years of age, and this forms the majority of the bulk of patients with low back pain. In elderly, although the prevalence of low back pain reduces, but the unique causes like compression or the metastasis or infection have to be ruled out in these patients. So before going on to the evaluation of these patients with further investigation, we'll briefly see few cases that have come to us, different age groups. First case is a case of 19 years female who presented with low back pain for 3 years, a gradual onset, which increased with activity, especially bending forward. There is no radiation of pain to the lower limb. The bowel and bladder habits are normal. There is normal appetite, no fever, no weight loss. She works in a bakery shop, and when we evaluated the severity of pain by visual analog score, she reported maximum pain to be 6 out of 10, and now the patient has 4 out of 10 severity of back pain. So on examination, when we observed the back, there was curvature or deviation of the midline furrow of the spine in the mid-back. There was a list of 2 centimeters to the right. The list is a deviation of the body, the whole body, the trunk is deviated away from the center of the pelvis, that is denoted by the gluteal cleft. The bilateral shoulders are equal, left hip is more prominent. The angle of truncal rotation that is measured during Adams forward bending test by using scoliometer is 20 degrees in the thoracic region and 13 degrees in the lumbar region, both on the right side. The abdominal reflexes are symmetrical, and the bilateral lower limb neurology is intact. Whereas the second case is a little older patient, 38 years, who presented with acute onset low back pain of 7 days duration while lifting a weight and radiating to the left lower limb for 4 days with tingling numbness in the foot that is aggravated with standing, walking or coughing, while reduced with lying down or by using painkiller. Again, the pain maximum score is 7, and now the patient has 5 because the patient is taking some analgesics. The bowel and bladder habits are normal in this patient. On examination, there is a list. The body is deviated to the left side. The straight leg raising test that we discussed earlier on the right side is normal, 80 degrees, whereas on the left it is reduced. So this shows there could be some knob root compression in the spine. So likewise, when you checked for the sensory and motor power, the sensory was reduced in L5 dermatome, and motor power was also reduced in L5 dermatome, except that everything was normal. And the reflexes were normal. The third case, even older, is a 56-year-old gentleman with low back pain for 2 months with severe intensity, which started after dragging a mattress and radiates to the left foot, increased with activity and lying down as well. The bowel bladder are normal. There is no perineal numbness or tingling. There is no constitutional symptom, no fever, and there is no history of trauma. And on examination, there is tenderness in the lower lumbar spine. It is moderate to severe tenderness. The SLRT is normal on both sides, the neurology is intact, and the reflexes are normal. So before discussing about the further evaluation of these cases, we'll see how we normally evaluate our patients presenting with low back pain in our clinic. So while sending for any imaging, referring for any imaging from the outpatient department, the referral note from the clinician must contain a clinical summary including relevant clinical findings and suspected pathology. That is very important because otherwise the radiologist cannot give you a very good diagnosis, the probable diagnosis, looking at the X-ray, CT or MRI or for that matter any other imaging modalities. So the X-ray is the first investigation of choice. We generally do lumbar spine X-ray, AP and lateral view, anteroposterior and lateral view in standing position, and it should be able to show T11 to the head of femur down below. And this gives information about the lumbar spine plus the hips and the sacroiliac joint. And we can measure some lumbopelvic parameters which are very important to see the deformity because of the degenerative disc or because of any other pathology for that matter. So this is the X-ray. Again, we have to see the alignment of the spine, the lordotic alignment of the lumbar spine. We have to see the in the AP view, both the sacroiliac joints and the hip joints. In the lateral view, both the hip joints should be seen right from T11, so that we can measure some angles like PI or some pelvic tilt or some angles like lumbar lordosis in these X-rays. And in these X-rays, we have to see for some signs of degeneration, like the traction spur is an indication of instability of the spine. It's whereas the spondylophyte, the claw-shaped spondylophyte, shows the degeneration of the disc, and this should be distinguished from traction spur, which is more of a sign of instability of the spine. Likewise, another important sign to be seen in the X-ray is a missing pedicle. In normal spine in the AP view, we can see the two pedicles and a spinous process making the two eyes and the nose of an owl. So when there is one pedicle missing, like in this side, so this is known as winking owl sign. So we have to see all the pedicles. Like in this case, there is one pedicle, and there is one more pedicle here, and this is the spinous process. So we have to look at every single pedicle while examining the X-rays. So in the other views, we have to look at the flexion extension, lateral radiograph of lumbar spine in standing position, or sometimes in older patients we can even do in lying down position. So this is the X-ray in the flexion and the X-ray in the extension. Both are lateral lumbar X-rays, and as you can see here, if you compare the two sides, this at level of L4, L5 spinous, the disc space, there is some increased mobility movement of the L4 anteriorly over L5. So this is the indication of spondylolisthesis. Sometimes, depending upon the probable pathology, X-ray of the whole spine is also needed, especially in cases with deformities like scoliosis. There is a new system of taking X-ray, which is called EOS imaging system, that reduces radiation to 1/10 the dose of the normal X-ray, and it can simultaneously take AP and lateral views at the same time, but this facility is not available at our place. So this is the X-ray of the whole spine, AP and lateral view, and the lateral view is very important to see the alignment of the spine, the normal kyphosis and the lumbar lordosis, as you can see here. Whereas in some cases, the patient might be more kyphotic because of some deformity of the spine, in which case we draw a line from C7 vertically down to see how much anteriorly shifted it is from the sacral. The oblique views used to be quite common to see the pars defect in the past, like this typical Scotty dog picture, but these days largely replaced by other imaging modalities like CT scan or MRI. And the MRI is the gold standard of investigation of any spine pathology, especially the cases with low back pain. It detects both bone and soft tissue structures with precision of the anatomy and tissue quality. And unless there is any contraindication, like metallic foreign bodies in the body, or the patient is claustrophobic, it is the gold standard and should be sent in most cases when needed. So the basic sequences in the MRI are the T1 and T2 weighted, and the axial T2, sagittal T1, T2, and axial T2 weighted images. Likewise, coronal T1 or T2 weighted images can be done in selected cases. And STIR, or the fat sat image, which are the fat suppressed sequences, are very important to see the fracture, tumor, or inflammatory processes. Sometimes the gadolinium enhanced enhancement is very important, especially to see the infections or neoplastic lesions. It also helps to differentiate the scar tissue from disc herniation recurrence. As you can see here, this L4 vertebral body appears to be disappeared on T1 weighted image, and is very much bright in this image, suggesting there could be some inflammatory process going on. Likewise, in this fat suppressed image, you can see the inflammatory process going on, and we can also see the involvement of the posterior ligamentous complex in the MRI. And this is a case of tumor metastasis. Sorry, this is a case of scar because of the previous surgery in the spine that we can differentiate from the recurrent disc herniation. This is the MRI, which is almost every day we come across in the outpatient clinic. A case of spinal stenosis. As you can see here, at the level of L4, L5, the disc is protruded back along with the hypertrophied ligamentum flavum. The space is very narrow for the knob roots, the cauda equina, to pass through this narrow space. This is the axial section, which was a very severe stenosis. The cauda equina knob roots getting compressed because of the compression from the buckling of the annulus from front, the hypertrophied flavum on the back on both sides, along with the hypertrophied facet joints. The CT scan is sometimes very important, but we have to be cautious to keep the dose as minimal as possible. As low as reasonably allowable is what they say while doing CT scan for patients with spine problem. The indications are the study of vertebral bone for facet arthritis, bony component of the central and lateral stenosis, vertebral fractures, implants, and focal bony lesions like osteoid osteoma, which is very well seen in CT scan. The axial, sagittal, and coronal CT scan are the ones which are done most commonly to see the bone and soft tissue. So, how we investigated our 3 cases. For the first case, the 19-year-old girl with some deformity observed on examination, who had presented to us with back pain for almost 3 years that increased with activity. So this was the X-ray done. This clearly shows there is some curvature of the spine at the level of thoracolumbar region. So this is a case of scoliosis. And for the case of scoliosis, we do some more investigation, some more X-ray imaging. That is right side bending and left side bending films to see how much the curve gets corrected with bending to the 2 sides. That is very helpful in deciding the correction and the osteotomy needed while doing surgery. Likewise, the other case who had presented to us with acute onset low back pain of 7 days duration with L5 weakness, both motor and sensory. This is the X-ray of the same patient, which looks fairly normal, and we have done the flexion and extension views. And if you look at the MRI in this case, at this location, you can see the disc protruding back and compressing over the knob root. Okay, the knob root compressed at this level is the L5 knob root that exits below the pedicle of the L5 vertebra. So L5 knob root is compressed. So this MRI picture correlates with the clinical finding in the patient. So I think the problem of this patient is because of the disc that is protruding from the its normal position, causing the knob root compression. Likewise, the third case was a 56 years male with 2 months history of back pain, who presented to us with fairly normal neurology. This is the X-ray, the alignment. If you look at the alignment of the spine, there is kyphosis in the lumbar region, which is normally lordotic. There is, if you observe carefully, there are degenerative osteophytes in the degenerative disc as depicted by the osteophytes at different levels. And at this level, the disc height is very much reduced, along with some loss of bone. The lower part of the L4 vertebral body and the upper part of the L5 vertebral body is lost, as you can see in this lateral X-ray. And when MRI was done for this case, we can see in T2 weighted image a bright single intensity at this level, suggesting This could be a case of infection, case of spondylolisthesis, causing some compression of the knob roots, but there is still some CSF seen, so maybe the knob neurology was normal because of this. So we also did CT scan for the patient, and the CT scan shows the level of bony destruction quite clearly in this case. This is the axial and this is the sagittal CT scan. The other tests which are not very commonly done but sometimes required if there is involvement of neurological structures are the knob conduction test, which evaluate the knob entrapments, and electromyogram, which studies the electrical activity of the individual motor units of the muscle and is useful for diagnosing neuropathies and myopathies.